In this particular audiocast, we will be talking about first breast cancer and the risk of it with hormonal contraception, followed by a discussion of what to do with challenging situations faced by the use of the LARC methodology. From the standpoint of what we will discuss relative to hormonal contraception and breast cancer will be, does the use of oral contraceptives increase the risk of breast cancer? Does the presence of a BRCA mutation change the risk among oral contraceptive users? And I might add, this would also include, for example, users of the patch and the ring. And does the use of progestin-only contraception, that would be Depo or the progestin-only preparations, increase the risk of breast cancer? But to put it in perspective, I think we have to understand that there are a lot of factors in the early development of breast cancer. There's genetic factors such as repressor genes, proto-oncogenes, there's growth factors, including estrogen and even progesterone, as well as other growth factors. And there's tissue factors related to the basement membranes, immune shielding, as well as angiogenesis. And trying to tease out how oral contraceptives or the patch may lead to the development of breast cancer when there are a whole host of various factors that can influence it is a difficult epidemiologic task. It's also important to keep in mind that the time from when a breast cancer first develops to when it can be detected is a matter of 5 or 6 years in many instances. And again, this certainly would support our approaches to screening. But also is important to recognize this presents challenges for epidemiologists as well. So that if, for example, you are studying women who've developed breast cancer, and again, you would probably have to follow a number of women or develop a database of a lot of women with breast cancer over several years, and that when you actually do the study and show an association between those breast cancers and, let's say, the use of hormonal contraception, because there is this 5 or 6 year development process, what you are seeing may not in fact reflect the current use of contraceptives, but may reflect prior use of a different formulation of contraceptives. Again, something that epidemiologists have to address in their studies. So I'm going to review with you 3 classic studies that have looked at this particular problem. The first study was done approximately 20 years ago, and it was a large meta-analysis where about 54 studies were reanalyzed. And they included about 53,000 women with breast cancer and 100,000 controls. And these were primarily case control studies and obviously observation studies by being that. The evidence suggested that oral contraceptive users aged less than 35 years did have a slightly higher risk of being diagnosed with breast cancer. But once they stopped using the pills, their risk declined over time, such that by age 50, the cumulative risk of breast cancer diagnosis was the same both in users as well as non-users of oral contraceptives. There was no evidence that oral contraceptives, even higher dose ones, increased the risk of breast cancer, even with increasing duration of use. There is no evidence that family history of breast cancer modified the risk, and it's important to recognize that findings could be due to detection bias, meaning more oral contraceptive users get breast exams than did the controls, or may reflect that the oral contraceptives promoted some growth of already pre-existing tumors and weren't actually etiologic. The second study, done about 8 years later, was a large case control study, which I was fortunate enough to be a investigator in, and this included about 4,600 cases and about 4,700 controls. The controls were population-based through random digit dialing, which again is felt to reflect the general population better than hospital controls. The women were aged 35 to 64. Data was collected from cases in various so-called SEER registries or cancer registries between the diagnosis being made between 1994 and 1998. As shown, a high percentage of both cases and controls had used oral contraceptives, but there was no identifiable risk of breast cancer in women who had ever used any type of oral contraceptive, as shown here. And also, among women aged 35 to 64 years, current or former oral contraceptive use was not associated with an increased risk of breast cancer. There was no increase in risk for longer periods of use or for higher doses of estrogen. and the initiation of oral contraceptive use at a young age was not associated with increased risk, and a family history of breast cancer was not associated with increased risk. The final of these 3 studies is more recent, again another decade or so later, and this included 23 studies, 15 were case control, 8 were cohort, involving, again, a large number of subjects in the analysis. Here again, the risk of breast cancer was exceedingly low, again, an odds ratio of 1.08, and the risk, again, was with recent use, with risk decreasing over time as people discontinued their use. There was no effect of duration of use, and the approximate increase in lifetime risk of breast cancer among oral contraceptive users was less than 1%, again, about 0.9%. So what about the risk in a higher risk population? And these are those with the BRCA1 and 2 mutations. And unfortunately, there's not a lot of data reflecting all of this. And there was 5 studies, 3 case control and 2 cohort studies that were involved in a meta-analysis, which involved about 4,500 subjects. So there were a substantial number of person years in a single study. The overall risk among oral contraceptive users was not statistically significant, and again, quite low, very similar to what we saw with the general population studies that we just discussed. And there was no effect of duration of use. However, the data was inadequate to analyze the effect of a positive family history. So at least it's somewhat reassuring. And what about progestin oral-only contraceptives? Here, there's a real paucity of studies as well as the quality of data. In fact, only 6 articles in this particular study listed here that was published in 2016 underwent systematic analysis. 5 of the 6 articles reported no association between use of any form of progestin-only contraceptive and breast cancer, but it's clear more rigorous study is needed due to the small sample size, variations in progestins and route of administration, and the heterogeneity of study locations. So, to answer the 3 questions we posed, does the use of oral contraceptives increase the risk of breast cancer? Minimal, if any, increase, and some of this could be on the basis of bias. Does the presence of a BRCA mutation change the risk among oral contraceptive users? The answer is no. And does the use of a progestin-only contraception increase the risk of breast cancer? Here again, the answer is no, but there is a paucity of data. Our next topic will deal with LARC management issues and challenges. And again, the issues that we will discuss, and this is part of a recent ACOG publication, will be painful IUD insertion, missing IUD strings, non-fundal placement of an IUD, positive pregnancy test with IUD use, and what to do when you have a contraceptive implant that you can't palpate and requires removal. First, the management of painful IUD insertions. A recent Cochrane review concluded that lidocaine gel and the use of nonsteroidals and misoprostol are not effective in reducing insertion pain in nulliparous women. Further, the effectiveness of a paracervical block was variable in studies. It may reduce the pain with inoculum placement. Some studies say it may offer some improvement with the actual insertion. However, with difficult insertions, one can consider the use of misoprostol or paracervical block, given that there's really not much else that you can offer at this point in time. What about non-visualized IUD strings? First, you see if you can visualize them, again, sweeping the cervical canal with a cyto brush. I might add that if you do get a phone call where someone says they no longer can palpate the IUD strings, it's important that they do use some alternative form of contraception until you have the evaluation. If the strings are brought down with a cyto brush, then obviously you go to routine care. However, if the strings don't come down with a cyto brush, you need to rule out pregnancy. You can offer emergency contraception if indicated, or use a backup method until IUD is confirmed in the uterus. And then you obtain a ultrasonography test. If the IUD is visualized, you go to routine care, and there's really no need to do further confirmatory ultrasonographies later. If the IUD is not visualized in the uterus, you need to obtain an X-ray of the abdomen and pelvis. If it's not visualized on X-ray, you assume that the IUD has been expelled, and you again have some contraceptive counseling. If it's visualized on the X-ray and obviously is not in the uterus, you proceed with laparoscopic removal. Leaving the IUDs in can lead to certainly significant inflammatory changes. Occasionally, you may want to do a replacement of the IUD with direct laparoscopic guidance, but this takes counseling prior to the surgery. When you'd have a non-fundal IUD noted on ultrasonography, but the IUD is in the uterus, basically the management is the same depending on whether you have symptoms of bleeding or cramping or the patient is asymptomatic. If the IUD stem is above the internal os, you can counsel the patient. If she's having symptoms, you can consider giving her things like estrogen, and you have to point out to her that it is likely the IUD will continue to work, particularly if it's a levonorgestrel IUD, but unfortunately it may or may not be as effective as if it were fundal in location. This is the same discussion you would have with an asymptomatic woman. If the IUD stem is below the internal os, that is, part of the IUD is actually in the canal, it reflects partial expulsion. The IUD should be removed, and obviously contraceptive counseling would then occur, possibly a discussion of replacement of the IUD. What do you do if you have a positive pregnancy test with an IUD in place? First, you obtain an ultrasound. If you diagnose an ectopic pregnancy, then obviously you discuss medical versus surgical management. If the IUD is in the appropriate location, it can be left in afterwards if the patient so desires. If you identify an intrauterine pregnancy and it's undesired pregnancy, you can remove the IUD at the surgical abortion or medication abortion. If it's desired pregnancy, you perform a pelvic exam, and if the IUD strings are visualized or not visualized, determines what you do next. Here again on the left upper square, if the IUD strings are not visualized or not recovered at the time of the abortion, here again you would do as we did with this last protocol, that is to obtain an X-ray of the abdomen to determine whether it's been expelled. If it's obviously there and the pregnancy is desired and you can see the strings, gentle traction should occur. If on ultrasonography no IUD is visualized in someone who again wants a pregnancy to continue, again you do the X-ray of the abdomen after the pregnancy has been resolved or delivered. The IUD is noted in the cervix, it should be removed. The IUD is above this cervix, you do not attempt removal, but you do counsel patients about the risk of preterm delivery and the like. Here again, the reason for removing the IUD is there's an increased miscarriage rate and potentially an increased risk also of mid-trimester infection. What do you do if you have a non-palpable implant? Certainly, here again, you must exclude pregnancy and recommend backup contraception. Oftentimes, it's a matter of trying to it's determined really at the time that you're either removing the implant for another pregnancy or you're doing the process because the patient wants to use a different form of contraception or needs replacement. So we determine the type of implant and, if possible, the site of implantation. If it was a single rod an norgestrel implant with barium sulfate, you localize the implant with conventional two-dimensional X-ray, CT or MRI, or you can use ultrasonography that has a high-frequency linear array transducer. If it's a single rod implant of the newer types, you localize the implant usually with ultrasonography with a high-frequency linear accelerator transducer. Once it's been localized, you can attempt removal. You basically have to sort of mark it to the side and avoid marking right on directly, given that the location may not be there depending on where you place it. You can do this in the outpatient setting if the implant is not deeply located in a muscle and under a local anesthesia, but occasionally you're going to need an operating room, and if it's very deep near a neurovascular bundle, you need to utilize a surgeon who has experience operating on the arm. So these are our two areas of discussion for this particular audio cast.